Hello everyone, welcome to my YouTube channel. Today we are going to talk about VTE, venous thromboembolism, that comprises of DVT and PE, part 1. Before we start, there is a disclaimer. This video is for informative purposes only. I am advising you to refer to the main textbook or sources that is used in each teaching center respectively. Thank you. Now let's begin. What is DVT? DVT is a formation of blood clot in deep vein of lower extremity. What is embolism? It is a blockage of blood vessels by solid, liquid or gas at site distant from its origin. Now let's talk about coagulation pathway. The coagulation pathway is a cascade of events that leads to hemostasis. This pathway allows for rapid healing and prevention of spontaneous bleeding. The two pathways originate separately but meet at a common pathway, leading to a fibrin formation. In intrinsic pathway, it started with activation of factor 12 to factor 12A in activated form after exposure to endothelial collagen. Factor 12A acts as a catalyst to activate factor 11 to factor 11A. Factor 11A acts as a catalyst to activate factor 9 to factor 9A. Factor 9A acts as a catalyst to activate factor 10 to factor 10A. This is known as a cascade. When each factor is activated, it goes to activate many more factors in the next step. The intrinsic pathway is clinically measured as partial thromboplasty time, APTT. The extrinsic pathway is a shorter pathway of secondary hemostasis. Once damage to the vessel is done, the endothelial cells release tissue factor which activate factor 7 to factor 7A. Factor 7A goes on to activate factor 10 into factor 10A. This is where both extrinsic and intrinsic pathway become a common pathway. Extrinsic pathway is measured as prothrombin time. In common pathway, the factor 10 in activated form will act as a catalyst to change prothrombin to thrombin, factor 2 to factor 2A. Factor 2A, thrombin, will act as a catalyst to stimulate fibrinogen to fibrin. And fibrin, with help of factor 13A activated form, will change to fibrin polymer that prelude for clot formation. Risk factor of thromboembolism is based on Virchowstriad that consists of A. Venostasis, B. Hypercoagulable state, C. Intimal or endothelial injury. For Venostasis, anything that slows or obstructs the flow of venous blood. There is an increase in viscosity and formation of microthrombi that is not washed away by fluid or movement. Thrombus grow and propagate. Stasis costs more time for clotting, and these more clots will not wash away. This will increase blood viscosity. Factors that contribute to venostasis include embolism, bed rest, where there will be reduced muscle motion, thereby reduce venous blood flow, causing venostasis. Paralysis. Pregnancy because compression of the inferior vena cava, causing venostasis. Varicose vein. Obesity. In obesity, patient is in secondary lifestyle, whereby there will be a poor venous return. Congestive cardiac failure patient, and patient who in extended sitting position during a long haul flights. B. Hypercoagulability state. There is an increase in circulating tissue activation factor and reduce in circulating plasma, antithrombin, and fibrinolysin. There is also a biochemical imbalance between the circulating factor. In hypercoagulability state, there is reduce in coagulation inhibitor, antithrombin 3, presence of activated factors that increase in also an increase in tissue factor. Factor causing hypercoagulability: A. Smoking. B. Malignancy. In malignancy, there's an abnormal release of coagulation that promotes cytokine to increase the coagulability. Birth control pills and pregnancy also, whereby estrogen promotes hypercoagulability, especially in presence of other risk factors. Increased blood viscosity, and E. Underlying clotting abnormality. Example, factor 5 Leadin, protein C and protein S deficiency, antithrombin 3 deficiency, activated protein C resistant that will increase blood clotting ability. C. Internal injury or endothelial injury. Usually due to external trauma, it is an intrinsic factor. Due to surgical trauma or accidental trauma, during injury, there is activation of coagulation cascade that leads to hypercoagulable state. Pathophysiology of deep vein thrombosis involve stasis, fibrin formation, clot retraction, and propagation. For stasis, there is an activated factor accumulation, thrombin formation occurs, platelet aggregate, and platelet release reaction. Fibrin formation, thrombin is absorbed by fibrin and neutralized. 3. Clot retraction, thrombin release causes platelet aggregation. And 4. Propagation, successive alternate layers of fibrins and platelet. Clinical manifestation of DVT is based on symptoms and signs. Symptom is redness, increased warmth, leg pain, mild fever, unilateral leg swelling. For the signs, warm, erythematous, tenderness. Hormone test or dorsiflexion sign is positive. Hormone test is whereby there is a calf pain at dorsiflexion of foot. The problem by doing this test is risk of detachment of thrombi during procedure causing embolus. 3. Bancroft or Moses sign. It is positive if pain is elicited when the calf muscle is compressed forwards against the tibia. Differential diagnosis of deep vein thrombosis include A. Cellulitis, B. Ruptured Baker cyst, C. Compartment syndrome, D. Superficial thrombophlebitis. For diagnosis, I am using a Wells score for DVT. It's easier for me to divide it into a risk factor and symptom during presentation for easier memorization. For risk factor, active cancer, treatment within the last 6 months or palliative care, you can give 1 mark. Previous documented DVT can give 1 mark. Paralysis, paresis, or recent cast immobilization of lower extremities can give 1 mark. Recently bedridden more than 3 days or major surgery requiring regional or general anesthesia in the past 1 month, I will give 1 mark. Symptom and sign. Swelling of the entire leg give 1 mark. Calf swelling more than 3 cm compared to the other cuff measured 10 cm below the tibial tuberosity can give 1 mark. Localized pain along distribution of deep venous system can give 1 mark. Collateral superficial vein non-varicose can give 1 mark. Pitting edema that confined to symptomatic leg can give 1 mark. Alternative diagnosis at least as likely need 2 minus 2. Interpretation of Wells criteria is like this. If more than 2 marks, DVT is likely. Consider imaging the leg veins. If less than 2 marks, DVT is unlikely. Consider blood test as Ddimer to further rule out DVT. So what is Ddimer? Ddimer are fibrin degradation products which arise when a thrombus is degraded by fibrinolysis. Many factors that can cause elevated D-dimer, but if D-dimer is negative, I can safely rule out DVT. The fate of thrombus can be divided into propagation, embolization, dissolution, organization, and recanalization. For propagation, thrombus will accumulate platelet and fibrin causing obstruction. For embolization, thrombi may dislodge and transport to the other side. Dissolution, whereby thrombi removed by fibrinolytic activity. And lastly, organization and recanalization. Inflammation and fibrosis occur, become organized. Recanalize happen whereby there is a establishment of vascular flow occur, incorporated into the thick vascular wall. Okay then, that's all for today. Let's continue part 2 in another video. See you next time. Bye.